Today we will discuss the diagnosis and management of neuropsychiatric lupus. It's just like fire in the cockpit. Central nervous system lupus is one of the most complex clinical scenarios in acute medicine. It's everything, has no single diagnostic gold standard test, and carries the highest risk of permanent disability if mismanaged. Success relies on ability to rapidly separate inflammatory, immune mediated from thrombotic or ischemic, because the pathways to treat them are different. So first we will discuss the diagnostic dichotomy, whether it is inflammatory or thrombotic. When SLE patients presents with an acute onset neurological deficit, altered mental status or psychosis, your absolute first priority is to categorize underlying pathophysiology, because you cannot treat CNS lupus properly until you determine if the brain is on fire or the plumbing is blocked or it's thrombosis. First we will discuss the inflammatory phenotype, the fire type. Here the pathophysiology is driven by direct autoantibody mediated cellular dysfunction, blood-brain barrier disruption and local cytokine storm, especially elevations in IL-6, IL-8 and interferon alpha. The common antibody implicated include anti-ribosomal P antibodies, which has got high association with acute leukocytosis, and anti-NMDA receptor antibodies, which produce a diffuse encephalopathy. Clinical presentations can be acute confusion states, leukocytosis, aseptic meningitis, transverse myelitis, and even chorea. So the primary treatment is immediate aggressive immunosuppression. Now let's see the second part, the thrombotic or the clot phenotype. Here the pathophysiology is usually driven by antiphospholipid antibodies, specifically the lupus anticoagulant, anti-beta-2 glycoprotein and anticardiolipin antibodies. This produces a hypercoagulable state, leading to focal macrovascular strokes or small vessel microthrombosis without true vessel wall inflammation. So the clinical presentation would be focal ischemic strokes, transient ischemic attacks, multi-infarct dementia, or specific patterns of intractable headache which occur in cortical venous thrombosis. Here the primary treatment is not to control the inflammation but anticoagulation or antiplatelet therapy, and never high-dose steroids. So how do you go about the practical workup to separate these two? There is no single lupus brain test. Diagnosis is a puzzle put together by ruling out mimics, especially opportunistic infections in an already immunosuppressed patient, and identifying objective tissue markers which are when they are available. So the first thing